Hi everyone, thanks for listening to our talk today. We're excited to talk with you about an innovational relationship that we've been able to capitalize on for the past 15 years as a department. WVU Emergency Medicine is a well-established department with an EM residency program founded in 1993. We're located in north central West Virginia and clinically serve patients from throughout our state as well as the surrounding states. Over the past 27 years, the department has continued to expand and currently has a large departmental umbrella, inclusive of our main academic training site, Ruby Memorial Hospital, our primary community hospital and secondary training site, United Hospital, known as UHC, and a multitude of community and rural hospitals that our department oversees ED operations and staffing for, as you can see on the slide. Just like everyone else over the past 5 years, we have had explosive growth as we continue to incorporate community and rural hospitals into our health system. This leaves us with a multitude of sites that are technically a part of WVU Emergency Medicine, but have no real knowledge of how to incorporate education of residents into these environments. They may also have faculty members who, quite frankly, are not interested in teaching and don't have the skill sets for doing so. Our earliest relationship with a community hospital, which we're going to speak of today, dates back to 2005 and has grown to be a very synergistic relationship where our emergency medicine residents love the rotation and the community experience. The faculty are engaged in teaching at the bedside in our didactic curriculum and also occasionally involved in scholarly work as well. It is essentially called our academic feeder hospital, community site that allows junior EM faculty members to test the waters of academia after graduation, with frequent opportunities for bedside teaching of EM residents while simultaneously learning their own independent practice style and fostering a pathway forward for full academic careers for those that find their particular niche in academics. We refer to this model in our own terms at WVU EM as a splitter model, where the EM faculty essentially splits their time, their monthly FTE, if you will, between the primary academic site and the community site. We have ultimately been able to use this model of practice to recruit many of our own program graduates into this position, with further delineation into either a full-time community or an academic faculty position, or sometimes a continuation of a hybrid position. All of us speaking today started our EM careers while working in these splitter positions and ultimately transitioned to our full-time administrative positions at our primary academic site. For today's talk, we would like to specifically focus on our collaboration between our primary academic site and residency program and our community hospital, United Hospital Center, UHC. United Hospital Center is a state-of-the-art community hospital in Bridgeport, West Virginia, about 35 minutes south of our main campus in Morgantown. Since 2005, the Department of Emergency Medicine at WVU has been involved synergistically to offer our EM residents the opportunity to train in a true community environment while simultaneously reaping the benefits of financial support for the residency program, as UHC currently pays for 3.3 full-time employee residents in our 10 resident per year training program, in return for the standard provision of 18 shifts of resident staffing per month at UHC. As we all know, in the era where program expansion and new program development is significantly limited by Medicare and GME funding, and community EDs often find themselves in need of additional healthcare providers, often in the form of APPs or advanced practice providers, novel opportunities such as these relationships are crucial in finding ways to promote the growth and expansion of already existing programs. Above and beyond the financial benefit to our program, the community experience at UHC really offers added benefits to both residents as well as the EM community faculty, inclusive of increased resident experience and satisfaction with community emergency medicine training, access to procedures, and direct interactions with community hospitalists and consultants to truly prepare them for any practice they face after graduation. For EM faculty at our community site, the opportunity to work side by side with emergency medicine residents, foster mentorship and educational opportunities, all while seeing patients independently as well, promotes career satisfaction and longevity. The relationship has proven to be very successful in terms of recruitment and retention of our EM faculty at the community site, as we are frequently able to maintain and retain graduates from our own program as faculty hires at UHC. We're going to use the rest of our time to outline the specifics of how this relationship has been developed at our own institution and how you too can potentially develop a similar relationship at your own institution. The objectives from our talk, as seen on our slide, are going to be the following. Discuss the growth of community-affiliated sites and implications upon traditional academic missions. Analyze the impact of metrics in the community setting and the challenges they can create for academic departments. Analyze how having residents in a community setting can lead to financial benefit for the residency program. Describe how the presence of learners can influence faculty recruitment and retention in the community staffing positions. And describe how implementing educational rotations at community sites can positively affect learner satisfaction and procedural experiences.
So thank you, Erica, for that great introduction. Hi, everyone. My name is Chris Goode. I'm the chairman of emergency medicine at WVU. I'm going to take you back to 2005. For you White Sox fans that are watching this, congratulations. That's the last time you were pretty decent. But we're going to talk about how this relationship really came to be. So as Erica mentioned, back in the 1990s, we started a new emergency medicine residency program. We started it in an academic center that was very small, had very low volumes in the high 30,000s. So what the founders of our department did is they went out to community hospitals and they looked for partners. So through the late 90s, we had residents rotating at United Hospital Center. There were only two. We had residents rotating at United Hospital Center, but they weren't rotating as often as they do today. We also had residents that went to another community hospital. In 2005, we were approached as the academic department to provide the faculty staffing to United Hospital Center. Again, it's a small community in north central West Virginia. Currently, it's about a 55,000 volume emergency department. Back then, it was closer to 40,000. But they were having difficulty with recruiting and retaining physicians. For those that have been in the business for a while, you remember that the late 90s, early 2000s, there was some problems with malpractice in some states. West Virginia was one of those. So recruiting physicians to West Virginia was pretty difficult. So in 2005, when we implemented the faculty staffing arrangement, we made the decision to bring all of our community emergency medicine rotations to United Hospital Center. And we did that for a number of reasons. One, we thought that it would give a more consistent experience, both for the faculty that work there, so there would be a resident there every day, and also for the residents, so they weren't learning something new every time they came. So back in 2005, we started that, and it has only grown, as Erica pointed out, over the last 15 years. As far as the contract negotiation and how you get this started, it was actually pretty easy. The hospital, United Hospital Center, is actually part of our larger academic health system. So what we did when we started this, we looked at it as a way to recruit faculty, physicians, and maybe a way to retain people. And as Erica will talk about later, that's been one of the added benefits of having this rotation. When you look through, we're going to talk about how many people we've retained over the years, how many people we've been able to recruit to a hybrid position. So the contract negotiation was really based on that. It wasn't really based on productivity. It was based a little bit on the fact that this is a high volume emergency department as communities go. Also a very sick patient population. So having residents in the main emergency department to assist with the higher acuity patients and a lot of procedures had a win-win for both the faculty and the resident physician. So a couple years ago, we thought, wow, we should really look and see what are the financial effects. As Erica mentioned, it's been difficult over the years with different work hour rules that have been put into effect, added patient volumes to staff our emergency departments. And you have option of adding more faculty. You have the option of adding more residents if you can do that, and we've chosen to do that. And you can also add more APPs, which actually we've done that in conjunction. So we kind of made the decision, let's look and see what the financial effects of adding residents in the emergency department could be. And we wanted to look at it from RVUs generated in the main emergency department. So I call it a shared visit model. So that's when The attending sees every patient, whether it's seen by a resident physician or whether it's seen by an advanced practice provider. So we started to look at that with the cost of APPs going up. Fortunately, the cost of residents has stayed pretty stable over the years. And then we have the added advantage that we have spread the cost of operating the residency program over our entire 30 residency slots and not just start a new program, which some of our colleagues have published information on that, on the cost of starting a new program. So our main goal was to look at a number of things. What you see here on the slide is you see RVUs generated by year of training and also by the year, the academic year. So you'll see 15 to 16, 16 to 17, 17 to 18. I won't go through the slide, but you'll see the R1s through R3s and then an aggregate resident total and then an APP total, and those are RVUs per hour. What was interesting to see is that this follows very much what we think we would see in what we would expect to see in our academic departments, that as the residents gain more training, gain more efficiency, they see more patients. And in this slide, you see they're seeing higher acuity patients as well. Now keep in mind, we did not take into account in our study the advanced practice provider that's working in the lower acuity environment. That is a totally separate animal, and as we know, residents cannot work unattended, for lack of a better term. So totally, this doesn't apply to that metric. But one of the other things that we really wanted to look into was the direct staffing cost for every RVU that was generated. So when you take into account that an advanced practice provider costs well over $100,000 a year when you consider all of their costs, and a resident is much less than that, we really came up with some interesting numbers when you look at RVUs generated per dollar spent in direct staffing costs. And that's what you see here in Table 2. Now, when we take into account the cost of doing business, for the APPs, it's pretty simple. We take their hourly rate, which our market is about $52, $53 an hour, plus a fringe rate of about $12 an hour. And that gives us a total all-in cost of just under $65 an hour for an advanced practice provider. We look at the salaries of the R1, R2, and R3, and again, this is prorated for the amount of FTEs that United Hospital Center, the community hospital, is paying for. And we took that and we took their salary, and then we took the number of hours that they work, and that gives an hourly rate. We put in their fringe, and then we also added some program costs. And as Erica will talk about, we talk about program cost of lodging, food, mileage. We've actually also assigned some of our program management costs into that. And the hospital is agreeable, and in that 3.3 FTEs pays a fairly hefty overhead price. But if you look, the total hourly cost of a resident is almost 50% less than what an APP is. Somewhere closer around 35 to 40%. And if we go back to the slide before and you look at the RVUs per hour, especially in those R3s, where they're doing more RVUs per hour at 40% less of the cost, we looked at it and said, wow, we might have something here. So that's kind of what drove us to look at, is this an opportunity for programs like ours that are looking to fill the needs of any state, but in West Virginia, we've had a problem with recruiting for many, many years. And is this an opportunity for large academic systems that have close community affiliations to meet all of their missions, their educational mission, their mission to provide great care to the state, and also do it in a financially responsible manner? I think we would tell you we think so. We think there's an opportunity there. So down to the specifics of how this works. So we, at the beginning, well, actually about 3 months before every academic year, we project our costs. So back in March of 2020, we had the salaries for the residents for the academic year 20 going into 2021, as well as what we projected for our program management cost. And we provided all that information in a large yearly budget to the hospital administration. They look at it and they say, yep, we're going to get 8,000 hours of coverage for this cost. We'll take it. And then we invoice them on a monthly basis. They pay us. I don't know the specifics, but I do believe that there are some possible advantages on your cost report as that relates to your educational expenses. So that's something you really, when you get into this, you want to talk not only about the cost, but how it's reported and whether it's advantageous to your community hospital partner. And then the question is how do you get the faculty at this location, at this other location, at the community site, to really buy in? For me, it's pretty simple. I started there. Actually, coming out of residency in 2005, I was the medical director, which I did there for about 9 years until moving into some other roles. And so it's pretty easy for me because all the faculty that work at the community site are employed directly by the university and by the Department of Emergency Medicine. But more importantly, we get buy-in because it's a very unique opportunity to work. It's what we call the community hybrid model. So you get to go to work in a 55,000 volume emergency department that has many of the specialties, that has an admit rate well north of 20%, and you get to see your own patients. Occasionally you get to see a patient with a resident. You get to see a patient with an APP. So you get really all three approaches to seeing patients in a community emergency department. The advantages of being able to teach and being able to have fresh information coming in. It's a little annoying sometimes to the faculty when the resident comes in and says, oh, we just talked about such and such in Journal Club last week. And you're like, yeah, but I just want to treat the patients the way I have for the last 5 years. So I think a lot of the faculty look forward to that. I think it stimulates their brain. And to be honest with you, we haven't had a problem staffing that facility in the last 15 years. So the question is how do you get this started? Well, the first thing you do is you find your local community emergency department. You go talk to the hospital administration. You see, are they having issues? What issues are they having? You look and say, okay, as the academic department, can we staff it? Are we robust enough to staff it? Can we put together separate salary and compensation models? Because an academic job is very different than a community job. And then you go to the faculty and say, are you interested? Because if the faculty's not interested, I don't think this works as well as our experience has been. But I think this may be the future. This may be an opportunity for many academic departments that are struggling with meeting the workforce needs of emergency medicine in this day and age of limited expansion from the GME standpoint. And more importantly for us, it was an opportunity where we were able to meet our mission to take care of the people of West Virginia, but also to educate the future physicians of West Virginia.
Thanks, Chris. My name's Tom Marshall, and I just wanted to say that similar to Chris, I also am a former UHC ED medical director. At United Hospital Center in the emergency department, it's split into a vertical care or split flow model where the lower acuity patients are shunted towards an APP-driven area and the sicker patients are shunted towards the main ED. And this is where the residents largely practice. The resident hours include about 18 shifts per month per resident. As Erica said, 10-hour shifts. There's a morning shift, an afternoon shift, and we also have an intern shift where they begin to learn the way UHC works and get their toes wet in community practice. We feel that this is important because when we rely on them as a second and third year to function as a more senior resident, they have some experience there, which will help them kind of jump into it a little bit easier. As Chris alluded to, faculty turnover at UHC has traditionally been very low. Most of the turnover comes from our splitters who transition more towards either academics or some of them that decide just to be community faculty members. And I think that's one of the key points of UHC. It really lets people kind of find their niche and where they're going to be able to feel comfortable practicing long term. Of note, West Virginia traditionally has a high locums utilization, and we can say that at UHC since 2005 we really have had zero locums use at all. So that's pretty impressive for a state similar to ours. Currently, staffing at UHC includes 10 full-time faculty and around 4 splitters. 5 of those 10 faculty, as well as 4 of the splitters, did their training at WVU Emergency Medicine. The other faculty members either did medical school or residency training and left for a little while and then came back to WVU system. We have one faculty member that was dual trained in EM and family medicine and actually practices as an ED physician and a hospitalist. So that gives us a pretty unique relationship with the hospitalist group there. Graduates that we recruit from our program really feel comfortable with their colleagues. They feel comfortable with the system. They already know a lot of the community and hospitalist physicians that they work with. So it makes for a really easy transition to practice as an attending, which I think really is unique to this program. Another unique thing is that most of our administrative faculty, including all of us who are speaking today, have all at one time or another in our careers worked at UHC. So we don't have just the straight academic administrative folks that haven't experienced these community sites. And I think that's really important because when teaching residents, when hearing about issues that faculty members are having, it really is nice to have that perspective and understand what they're going through that you otherwise may not get in a straight academic program. And I think one of the unique things with teaching residents is that I will often ask them when I'm working at Ruby, which is our primary academic site, what would you do if you were at UHC? Because the management can be different in a community setting rather than an academic site. One of the things that we've been able to do really is recruit high quality emergency physicians. And medical students from our institution, who have trained elsewhere come back and they want to work at UHC after, their experiences there as medical students. So I think the opportunity really is there for either a hybrid or, straight community type position. But the ability to interact with residents really makes things a lot more interesting. The residents keep you on their toes, the residents keep us on our toes and up with the latest trends and changes, and I think that's really important to maintaining a high quality faculty long term. The EM faculty at the community site really in the beginning struggled with how to teach residents, but I think over time they've really bought in and play an important role in training these guys to move on to their attending roles. There are some that didn't want to teach or don't want to teach and now routinely win faculty awards. So I think that's something that over time really can develop a niche for folks that want to be in the community but want to teach residents as well. Some folks have said that in the beginning that they feel like residents are going to slow them down, but when we look at the data, length of stay data at UHC is significantly better than some of our other community hospitals as well as the academic site. So, that doesn't seem to bear out, and the left without rates there are routinely the lowest in the system as well, which really helps to show not only the faculty there but administration that residents can have a pretty significantly positive impact on the metrics that are tracked. This makes it an easy conversation with the CEO when we go and ask for more resources for the residents or want to add additional resident time there. There really isn't any pushback, and we've had great relationships with hospital administration there over time. The other thing that I think that is really important to touch on is that residents serve an important role in providing health care with direct staffing from an attending at a lower cost than APPs. As you've seen in the slides, they are significantly less per hour, and generally by second and third year they're functioning at or above the level when it comes to efficiency of an APP. Patient satisfaction is another important thing to touch on. Community hospitals are often very concerned with this. UHC routinely has the best patient satisfaction metrics between Presque Isle and ED Caps among all of our system hospitals. And I think that's a really important point. Not only are they better than our other community hospitals, but they're also better than the academic site. So I think that synergistic relationship with the residents and the attendings really helps to take UHC to that next level.
Thanks, Tom. I'm Chris Kiefer. I'm the Associate Program Director here at WVU. And my background is that I'm a native West Virginian, but left the state for residency training in Minnesota, and then followed my wife to a neonatology fellowship in Indiana. And while I was at Indiana, I actually worked in a hybrid position at Indiana University, where I worked time at our county hospital and then also time at a community hospital in a very ritzy suburb of Indianapolis. And one of the things that we did while I was there was we actually introduced medical students into the learning environment. The hospital I was working at had been open about 2 years at that standpoint. It was actually opened with the intention that a learner would never set foot in the hospital. We worked with our educational leadership at IU to sort of expand the clerkship to this site. And one of the biggest concerns that people had as we brought learners into a very high pressure from terms of patient satisfaction and reimbursement environment was what will happen to our patient satisfaction scores that the hospital is looking at so closely with the initiation of learners. So we did a study actually at Indiana that looked at, the nice thing about this was we had 2 sites that came on board throughout the study period. We had no learners at all, and then we had learners start after a certain discrete date, which is relatively unique in emergency medicine, and we were able to track patient satisfaction trends over time. What we found was that at both sites, before and after the introduction of learners this is NRC picker data, which is a little bit different from Presque Isle, it's an alternate vendor, there was no statistically significant difference with patient satisfaction data on top box scoring for the 2 main questions that people care about. Would you recommend this hospital to your family and friends? And what's your overall rating of this hospital on a scale from 1 to 10? So the 2 sort of questions we were assessed on. The top box scoring really didn't change in any significant manner before and after the introduction of students, with the exception that there was a trend towards the positive after the introduction of students and a statistically significant increase actually in the overall score for all patients at our first site that we introduced medical students for. So to sum it up, our UHC site has patient satisfaction data that's above the national average and the best in the system. And one of the few studies that's out there actually shows a trend towards improvement in patient satisfaction after the initiation of learners. When I got back to WVU 8 years ago, one of the things that we were, I think, a little bit challenged at the community site was really having the residents and the faculty see it as an equal part of our academic mission, as sort of a second main site of the residency program. I think prior to that, a lot of people sort of saw the residents as an extra set of hands that day, an extra set of procedural hands, and the residents sort of viewed it as they were there to get a little bit more procedural exposure and procedural experience. And one of the things that we've worked really, really hard on in the almost decade that I've been here is really integrating it as a full residency site where the faculty give ownership and autonomy to the residents. That's our goal, is that the residents get exposure to a community site and have the ability to independently run a pod, to talk to community attendings, and really manage patients in an entirely different setting than the academic setting. There's been challenges. There's been hard times at doing this, and the ways that we've done this, or the ways that we've overcome this, I think have a lot to do with our splitter model that Erica referenced at the very beginning of this talk. We use this site as an opportunity for some of our junior faculty to sort of get their feet wet in academic medicine. They work some shifts at our main shop at Ruby, and then some shifts at UHC. On those shifts at UHC, they're really able to sort of be the interface between the resident and the nursing staff when there's a conflict. They understand the goals and objectives of each rotation, and really the difference in graduated autonomy between different levels of resident training. And they're able to sort of facilitate those discussions. So when ex-nurse comes to the faculty member, it's like, oh my gosh, this July 2nd year is so slow, it is so painful. They're really, really great about kind of pushing back on the nurse and be like, hey, this is a process, and this is where they are in the process, and to pay those benefits of having a really great third-year resident who's running the pods independently on a hectic shift a year from now, we really have to support and give that resident sort of the skills that they need to succeed. All of our faculty members, as everybody else has sort of alluded to, are board-certified emergency physicians, and I think a really, really important part of having them, having the UHC rotation be viewed as equal to our main academic site is the fact that they're employees of the department. They are faculty members that all have academic appointments beginning at the assistant professor level. They are not challenged the same way as our academic faculty are with regards to sort of the three legs of the academic stool with regards to clinical work, teaching, and research. If they choose to focus on clinical work alone and being great teachers at the bedside, they don't have the same pressure to advance to the associate professor level that some of our main site faculty do. But I think it's really important that they're evaluated by the chair on an annual basis. They have an academic-focused sort of feedback meeting every year with the medical director at that site that focuses on clinical productivity, work RVUs, metrics, but also focuses on their teaching evaluations, focuses on the didactics that they gave and the evaluations they got from those, and their performance as an academic faculty member. We afford access to all of our UHC site faculty to any sort of resource the university has with regards to their academic pursuits. So if they are someone who likes to write, they have access to our Division of Research and our research support just like any of our main site faculty. If there's someone who has an interest in developing as a medical director or a business leader, our department will support them participating in the ASAP Medical Directors Academy. We work really, really hard to make sure that our faculty at that site are viewed as equals and as much a part of the department as our program director, our associate program director, our medical directors, anybody else in an administrative position. The faculty do get evaluated on our learning management system, and the results of those evaluations are shared with them annually. We look at our rotation evaluations for UHC really, really closely. Our PEC, our Program Evaluation Committee, reviews that on a semi-annual basis. And I think the consistent themes that you can see on these slides are that the residents love their faculty. They appreciate the autonomy that comes from the UHC experience. They really appreciate the procedural experience. They feel like this is a huge part of their training. One of our goals as a residency program, our overarching goal, is to train our graduates to go wherever it is that they want to go and do whatever it is that they want to do. If they want to work in the community in West Texas, if they want to do an EMS fellowship at UCSF or an international fellowship at Brown, or they want to work in a rural community somewhere else or in the community in Miami, we are here and we aim to prepare people to do that. And I think a huge part of that is our UHC experience. So when we talk about making sure that our community faculty are integrated into our academic mission, one of the other things that we afford them access to and actually require all of our faculty, regardless of primary site, in their first 5 years to do is participate in our faculty development program. Our faculty development program is starting its second year in its full deployment, and it consists of some of our academic leadership faculty really giving tools and rules of the road for junior faculty to succeed. It teaches them the intro to the P&T process. How many publications do you need to go from assistant to associate professor? How many committees do you need to serve on? What is considered adequate progress? How many years should it take you if you're the average performer to go from assistant to associate professor? It gives them access to our research faculty who come in and do a full day boot camp that looks at everything from how do you fill out the IRB proposal? What are some pitfalls in filling out an IRB proposal that are going to get you rejected? How do you pick the journal that you're going to submit to? How do you make your academic writing clear, concise, and scientifically oriented? The residency leadership really works with them on bedside teaching in the faculty development program. We have an entire day devoted on concepts like the 1-minute preceptor, ways to teach when you're busy, how to give feedback at the bedside, how to write evaluations that are meaningful for residents. It's really just a how-to be an academic faculty. We make sure also that the UHC faculty have representation on our clinical competency committee and our program evaluation committee. I think these are two essential steps to making this partnership succeed. From the CCC standpoint, the evaluations that we're getting from the community faculty are oftentimes observations that are difficult to make in an academic setting where there's tons and tons of learners. They often regards to efficiency, ability with ownership. Are they functioning at the level that you would expect a late second year or early third year resident to function at? I think we get a ton of insight from those. It also, for the residents, makes sure that they take that rotation seriously and really view it as a second main site of the residency program. They know that those evaluations are meaningful, that they're going to be incorporated into the CCC, and the UHC faculty member will be there with the ability to sort of provide all of the feedback from those faculty that may not be written down. On the program evaluation committee side, this is the way that we make sure that everything that happens at UHC or the quality of the rotation is staying as fresh as possible, that if there's improvements that need to be made or there's a certain faculty member that may not be letting people out on time or may be overly aggressive about picking up patients independently, we have a way to get that feedback back to that faculty, make sure that it's heard by the program, and make sure that we deal with it in a timely fashion. I think one of the biggest challenges in this partnership has been, what do we do when a faculty gets a bad eval, or what do we do when a faculty no-shows a didactic experience? We make sure that each UHC faculty member has the opportunity, or the requirement really, to give one didactic experience per year. I think that's an important part of making sure that those faculty see the academic side on teaching as part of their primary mission. I think it's important in sort of the integration, seeing one residency, two main sites. I think that we have had the challenge of somebody forgetting, not coming, not blocking their schedule. And that's really incumbent on our relationship with the chair to enforce. We have actually a fine system where that if somebody doesn't show up, there's a portion of their academic bonus that's withheld for the UHC faculty as well if they no-show a lecture, or if they come and they bash the residents in a lecture, or their evals are notoriously poor. And I think that really gives the teeth. I think, to be quite honest with you, there may not be as much reward for some of our community faculty seen in things like buy down or grant money that might be part of the traditional academic mission, but compensation does seem to be a motivator. Since we've implemented the fine system, we've actually gone about 3 years without a no-show for a lecture. Everybody, even if they forgot to request off, seems to be able now to make a swap or make it work for their schedule to make sure that they're there. They're actually giving fresh content. They take their lectures very seriously. They incorporate what they learn in the faculty development program for how to give a lecture and do their best. And I think it's been really inspiring to watch over the last 8 years as we've gone from some of the challenges in launching this partnership to really, it is one residency program, 2 sites. The faculty are fully engaged with our academic mission and providing our residents with teaching at the bedside, teaching in the classroom, and incorporating feedback that we give them into their evaluations.
The procedural experience at UHC is also quite phenomenal. The opportunity to take care of truly sick patients in an environment with very limited consulting services affords our residents an abundance of opportunities that are often competed for in an academic learning environment, just by virtue of having ortho around for the distal radius fracture reduction, or ophtho immediately for the slit lamp exam because the patient was sent to the academic center to see ophthalmology. So the UHC experience not only gives the residents the opportunity to manage very complex patients, but it also gives them the opportunity to focus on lower acuity procedures as well, such as splinting, INDs of abscesses, simple and complex laceration repairs, which are sometimes quickly routed through a vertical care or a fast tack process, as we all know at our academic centers, when the resident is busy running multiple traumas and strokes and misses the fact that the lac repair actually got through the lower acuity pathway in the ED. The community experience gives the residents the luxury of a bit more time to focus on the completion of these lengthy procedures as well, given that they are still being supported by their EM faculty that continues to see patients in parallel to them while they are completing procedures, therefore maintaining the efficiency that's desired and expected in the community experience while allowing the residents some independence and procedural completion. Additionally, we have actually on occasion based on UHC as a site for procedural electives for residents noted to be struggling with procedural skills in general, and it has served very successfully in this role. You can see on the slide here our procedure counts comparing classes PGY2 and PGY3 between UHC and Ruby. UHC's PGY2 procedure numbers being 939, while UHC's PGY3 numbers, 715, are lower than the procedure numbers overall at Ruby, but in comparison to the amount of time residents are spending at UHC in comparison to the time they spend at Ruby, you can see that the numbers are certainly of high quality. Our most recent graduating class, as documented up here on the screen, has these significant numbers of procedures at their hands with logging limitations aside. Nonetheless, anecdotally, our residents will attest that the experiences they are afforded at UHC are very different than those they experience at the academic site, and the combination of both academic and community experiences truly helps them prepare for practice in any setting that they want after they're done with our program. The recruitment benefits of having this synergistic relationship with our academic site and our community site are tremendous. From the recruitment standpoint, the luxuries of having these multiple training sites all under one departmental umbrella, enabling the residents to get a comprehensive training and truly be prepared to practice at any setting as a capable physician after they are done with graduation, is a true gem when it comes to recruiting residents to our program. There are not a ton of program out there that can say that they truly have a department where staff work alongside them as board certified EM physician, that their residents can truly get the academic, community, and rural training all within close proximity to the main site. So the academic community partnership affords you the opportunity to feel good about the comprehensive training that your residents are obtaining while in your program, and can definitely be used as a recruitment tool. Our opportunities for training at multiple sites during 3 years of training has always been viewed as a strength of our program when discussing with our own residents as well as prospective residency candidates. This has gone so well for our program that other programs within our institution, specifically pediatrics, is considering incorporating our community site as part of their own training program as well. So if you're interested in setting up a relationship between your academic site and the community hospital, we have a few nuts and bolts of setting up the rotation that I will share with you right now. So the first one would be establishing a program letter of agreement, or otherwise known as a PLA, and an affiliation agreement, otherwise known as an AA, with a community ED per your own GME criteria. Even if your hospital is operated by your department, it's always best to still have this site covered and marked by a PLA and an AA. And number two is making your schedule. With the assistance of chiefs and assistant chiefs, or whoever's responsible for this on your residency leadership team, you must make a schedule that is consistent and meets the logistical requirements of whatever negotiation your department has reached with the hospital, if the site is financially supporting your program in some way. For our program, this is the logistical negotiation of 18 shifts per month per resident working at the community hospital. Number three is designing evaluations for the faculty working at the community hospital that your residents will complete, as well as a rotation evaluation for the rotations that your residents complete at the community hospital. You can design these evaluations in accordance with your typical learning management system at your hospital. Number four is navigating the credentialing challenges specific to the hospital. Employing the assistance of your program manager is what we would definitely recommend, and potentially consider batch credentialing procedures and processes to make this a little easier on everyone. For example, as our residents start out our residency training program, we take all 10 of them down to our community hospital and fill out all of the appropriate paperwork that can be done empirically to make the credentialing process when they go for their first rotation a little more easily navigatable. Number five is reporting of the site as a secondary site in your annual ADS updates as program directors, which will include the annual ED volume of the site, the percentage of adult patients seen, percentage of pediatric patients seen, percentage of critically ill patients seen, et cetera, as you will be asked to do in ADS. Sixth, you want to educate your community faculty on the leadership's expectations of what the resident-faculty relationship and mentorship should be like as the resident works along the faculty at UHC. And I think we have to remember that this is probably a new working relationship for them all that definitely requires some attention to get things started off on the right foot. Seven, ongoing evaluation of the experience, quality improvement and process improvement of the experience, and that involves getting feedback from all stakeholders, including the residents rotating at the site, as well as the faculty working at the site. Some things that we have had to modify over the years include shift length, shift hours of the day to fit the community ED volumes. So those are some examples of things that you might have to keep an eye on as you get this process up and running. We used to do 12-hour shifts at our community hospital, but we've recently transitioned over the past few years to 10-hour shifts to allow for a little extra travel time for our residents to get down and back, particularly when there are inclement weather conditions or what have you. And 8 is consider financial support of your residents as they rotate at the community site. For example, you don't want there to be any sort of personal financial implications that would persuade the resident away from wanting to rotate at the site. For example, we provide gas mileage, lodging needs when necessary, and meal stipends for our residents who rotate at sites away from the primary academic center. Per ACGME common program requirements, if a secondary site is less than 30 miles away from the primary site, you're not obligated to provide housing. However, we do have call rooms available at our community hospital, and in the case where a resident needs to stay in a hotel for personal reasons, weather-related reasons, etc., all they have to do is speak with us and we'll happily provide that for them.
I'm going to talk a little bit about the myths or maybe some of the challenges that people would think would arise. The first one is when you introduce learners into the community setting, what does that do for your miss rate or your malpractice rate? Our experience over the last 15 years is that we have seen no significant change or increase in our malpractice claims when we compare across all of our shops. And again, we have about well in excess of 10 shops where we provide care to over 400,000 patients a year. So we've got a pretty good database. But one of the concerns is what is your malpractice rate? I can tell you that as far as community hospitals go, our malpractice rate is very low because, again, the attending gets to see and has to see every patient. So it's not like the academic environment where perhaps even on a floor somewhere there's a lot of care being provided by residents without direct oversight. In the community, the attending touches and evaluates every patient. So we haven't experienced that. The other question would be is, how do you integrate advanced practice providers and residents? I will tell you this has not been a problem for us, and I think for us it's actually been a very synergistic experience. We have advanced practice providers that work in our vertical care setting, so they have a certain amount of their time where they're practicing, albeit almost independently, almost outside of the main emergency department. It's a separate area of the ED. But we do have advanced practice providers that provide care in the main ED right alongside the residents. And that has been a huge, huge success. It's really nice when you have a first year, an intern who's doing their first month at UHC, and they've been a doctor for 6 weeks, 8 weeks. They've never used the slit lamp on a real patient. Perhaps they've never done a 2-layer closure by themselves. And we have the great fortune of having advanced practice providers. We have one with more than 20 years of emergency medicine experience in this location. And I'll tell you this day, when I cut my face, she's sewing it up. And she will go and she will take her time and she will teach the interns. She's probably taught more interns than I have in my 15, 18 years of clinical practice. So it's been a really great synergistic effect. Again, the APPs, they're like the faculty. They learn every day from the residents. They learn something new. A resident will come out, ultrasound's another perfect example. You know, our residents will ultrasound anything, eyeballs, things under the skin, just whatever. And the APPs have taken an interest. So the other way around is that the APPs will come over and say, hey, I need a DVT study done. Can you show me how to do it? So it's been a huge success, I think, in job satisfaction for our advanced practice providers, as well as an opportunity for our residents to teach. So I don't think, having APPs versus residents has been a problem for us at all. So I think what you'll find from this talk is that we've had a pretty good experience. Now, the expansion in the community sites, again, for us was easy because the community hospital, United Hospital Center, is part of our grander academic health system. So we have a number of hospitals in that health system. So when the faculty fall up under the chair and the medical director for community emergency medicine and have that similar environment, it does, I think, make it a little bit easier. But I think when you look under the hood, you look at all the other benefits that we see, and it's a financial opportunity for program expansion. It's a way to keep your costs lower as a health system in recruiting. And so it's a win-win both from an academic and from a financial mission. I think you do have to work with your community site to develop the expectations. That is really the biggest thing. And you have to, kind of develop how the relationship between the hospital and the academic department is going to work, both financially and operationally, understanding that everybody has a different motivator, and depending on the day of week or the week of the year, that motivator may or may not change. And I will tell you, the enhanced faculty recruitment and retention in our community site has been amazing. So again, I've been associated with this site for over 15 years. I served 9 years as medical director. I can tell you that since the inception in 2005, we have not used an external locums agency to staff in that emergency department, which anybody here that's on the, watching this from West Virginia will tell you that that's been a huge surprise. We have about 11 to 12 FTEs there, and in 15 years we've had 5 people leave. We had one departure, unfortunately, to death. We had a retirement of one of our faculty members, and then we had 3 people. One went to a VA system, and 2 went to work closer to home. So we consider that to be a huge, huge success for us. And then again, the residents, I think every year we watch very, very closely what the residents think about the rotation. We're very quick to respond to their concerns, but overall, they get to experience what 70% maybe or more of emergency medicine is, which is a community emergency department where you see anything and everything, sometimes with a lot of specialist help, sometimes with a little bit of specialist help. They get to do a bunch of procedures. They get to see the sickest patients. They don't have to stand behind people in line to do, anything if they don't want to. So the world is their oyster when they spend their months there. But I can tell you it's not without difficulty. Expect challenges along the way. Expect that every time it snows, your residency director, the chair, are going to sit there and go, oh my heavens, I hope nobody wrecks. Every time you get that call that somebody's wrecked their car, we've hit deer, we've slid into the median, we've banged a couple guardrails, but fortunately we've been successful in mitigating those risks. We also, occasionally life happens and people don't want to be away from home or they have concerns. And again, we're really quick to meet the residents' needs and at least give them answers, and we're quick to adapt. So overall, our experience over the last 15 years has been amazing. We are actually in the process of looking to how we can do this more, how we can do it in a more rural environment and provide a better experience, because we think we've got the community experience down pretty well for our residents. We'd like to expand that to rural America. So anyway, thanks for your time today. I hope you found our presentation very useful, and go Mountaineers.